Hi there, my name is Ashley Bennett and this is my Foundations of Disability Work Assessment 1 online presentation on microcephaly. I hope you enjoy it. Microcephaly is a rare, lifelong neurodevelopmental disorder where the infant's head is notably smaller than average. The Centers for Disease Control and Prevention has defined mild to moderate microcephaly as 2 standard deviations below the average occipitofrontal head circumference and severe microcephaly as 3 or more standard deviations below average. The World Health Organization suggests that microcephaly is present in newborn boys with a head circumference of 31.9 centimeters or less and newborn girls with a head circumference of 31.5 centimeters or less. An infant's head circumference should be measured within the first 24 hours after birth. The result will be interpreted in relation to the infant's gestational age, gender, weight, and length. There are 2 different types of microcephaly, primary and secondary. Although primary microcephaly is typically congenital or present at birth, it can develop postnatally. Secondary or postnatal microcephaly generally means that the brain is regular size at birth but fails to effectively grow afterwards. Secondary microcephaly can also occur in association with metabolic disorders or genetic syndromes. Microcephaly can be recognized and diagnosed during pregnancy through a prenatal ultrasound. However, it is not usually obvious until the 3rd trimester, at 28 weeks. When the infant is born, there are a range of tests that may be undertaken on the child to formally diagnose microcephaly, including measuring the infant's head circumference in relation to the World Health Organization's growth standards or performing CT scans, MRIs, X-rays, blood tests, or urine tests. General practitioners and other medical professionals can use the results from these tests to diagnose an infant with microcephaly. However, a diagnosis often does not provide an accurate representation of the impacts microcephaly will have on the infant or how they will develop through the lifespan. Aside from the noticeably smaller head circumference, microcephaly typically impacts the way the brain or nervous system grows. Children born with microcephaly often develop a wide range of developmental issues, including a smaller than average brain size, epilepsy, seizures and convulsions, cerebral palsy, mild to profound learning difficulties, developmental delays, vision and hearing impairments, short stature or dwarfism, a high-pitched cry, hyperactivity, facial deformities including a backward-sloping forehead, speech delays and language processing difficulties, poor fine and gross motor skills, balance issues and coordination difficulties, spasticity or shaky arm and leg movements, feeding or swallowing difficulties including dysphagia, repetitive hand wrangling movements, and sensory processing issues. However, in some cases, children with mild microcephaly do not experience any developmental issues, only a smaller than average head size. The life expectancy of individuals with moderate to severe microcephaly is significantly lower than the general population. When an infant is born or diagnosed with microcephaly or any other disability for that matter, it typically has large influences not only on the individual but also on their family and local society. The developmental issues associated with microcephaly can significantly impact an individual's cognitive, physical, emotional, and social skills. Children with developmental delays often require safe, nurturing learning environments where language and other tasks are simplified to their level. There is extra time to process, learn, and practice new skills, and require a variety of learning methods, including feeling, looking, and listening. When parents have one child with microcephaly, there is approximately a 25% chance of having another child with microcephaly with every subsequent pregnancy. The birth of an infant with congenital malformation often impacts the family dynamics in numerous ways, as it may cause feelings of frustration, anxiety, or stress for parents. Having a child with a disability often has large financial impacts as well as strenuous physical and emotional demands on the parents. Various studies have shown that siblings of children with microcephaly or other developmental delays often have more behavioural problems, lower self-esteem, and more prominent mental health issues in comparison to their peers without a sibling with developmental delays. These issues typically carry on into adulthood. However, on the other hand, many siblings have reported that having a sibling with microcephaly and/or other developmental delays has had a positive influence on their emotional and social development, as well as their empathy towards others. Living with a child or sibling with a disability can also have a positive impact on family cohesion and adaptability in stressful situations. The Australian Human Rights Commission suggests that negative attitudes, physical barriers, and limited accessibility frequently impact the opportunities people with disability have to engage in education, employment, or the greater community. Disability-based discrimination is a significant social issue that marginalises individuals, thus preventing social inclusion and cohesion. Microcephaly may be caused by a number of environmental and genetic factors, including genetic disorders or chromosomal abnormalities, severe congenital malnutrition, maternal exposure to toxic chemicals including radiation and arsenic, drug and alcohol misuse, maternal stroke, cerebral anoxia or decreased oxygen supply in the brain, maternal infections during pregnancy, which may include chickenpox, measles, rubella, herpes, syphilis, and HIV, and postnatal traumatic brain injury. Unlike Tourette syndrome, attention deficit hyperactivity disorder, and various other disabilities that impact one gender more than another, microcephaly is an autosomal recessive gene disorder, meaning that males and females are equally affected. The term recessive gene disorder means that the child inherits two mutated genes, one from each parent. Therefore, if only one of the child's parents is a carrier of the mutated gene, the child will not develop microcephaly. Statistics from the Centers for Disease Control and Prevention show that microcephaly affects approximately 1 in every 5,000 infants in the United States of America. Similarly, the Raising Children Network suggests that 1 in every 25,000 infants in Australia are diagnosed with microcephaly. Results from a comprehensive study undertaken between 1980 and 2015 in Australia showed that microcephaly is more prevalent in Indigenous Australian children than children who are non-Indigenous. This may be due to a range of reasons, including lack of access to healthcare services in remote communities and a higher rate of fetal alcohol syndrome disorder. Furthermore, between 2015 and 2017 in northeastern Brazil, there was a Zika virus outbreak. The Zika virus was a mosquito-borne infection. During that time, there were significantly higher rates of infants being born with microcephaly in Brazil. Researchers have confirmed that mothers who contracted the Zika virus during pregnancy had an increased risk of delivering infants with health issues and disabilities such as microcephaly. Although there is no current cure or treatment for microcephaly, some infants and children may benefit from taking epilepsy medication, while others may require tube feeding. There are, however, numerous early intervention services that can improve the child's overall quality of life. Multidisciplinary, collaborative professionals that can provide early intervention services for children with microcephaly may include pediatricians, neurologists, speech pathologists, audiologists, occupational therapists, and physiotherapists. These professionals will generally check the child's motor, social, intellectual, and language skills over a prolonged period of time. The National Disability Insurance Scheme, or NDIS, may provide individualised funding support for children and adults with microcephaly. NDIS funding is generally broken down into 3 categories: core supports, capacity building, and capital support. Core support funding can be used for consumables, daily activities, community engagement, and transport. There are 8 subcategories in capacity building, including choice and control, daily activities, education and employment, health and well-being, home living, relationships, community support, and support coordination. Lastly, Capital support funding may be used for assistive technology such as augmentative and alternative communication objects or devices and home modifications. So that concludes my online presentation for microcephaly. Thank you for listening. I hope you found it informative.